All right. Hi, everyone. Thanks for coming out. I'm Lyndsey. I'm the PA for Lakeland Urology. And I'm just going to start by covering incontinence in general, and then I'll go into urge incontinence, which is a certain type of incontinence. So urinary incontinence in general is the loss of control of urine. It's, you can't hold your urine until you get to a restroom. It can be a short-term or a long-term problem. Short-term problems are typically caused by another health issue, whereas long-term issues, something that you'll have to manage either with behavioral modifications, physical therapy, or medications. And it can range anywhere from just a little leakage, maybe a couple dribbles here and there, to complete loss of the bladder. So urge incontinence is one type of incontinence, and this is involuntary leakage of urine accompanied or immediately preceded by urgency. That's that feeling that comes on real quick. You got to get to the bathroom and you got to get there now. And that's often a difficult sensation to deter. So how do we diagnose this? How do we figure out what type of incontinence you're having? Well, if you come to the office, first we're going to get a history. There's different questions we like to ask to figure out what type of incontinence you're having. So we want to characterize the incontinence. When is it happening? Do you have urgency mostly? Do you have stress incontinence, which Cayla's going to cover shortly? Do you have components of both? And do you even have any sensation before you're going to have this leakage? We want to quantify the incontinence. How many pads are you wearing a day? Are you wearing adult diapers during the day, even with pads in them as well? Are you having to change your clothes throughout the day? We want to define the voiding pattern, and one nice way that we do this that I'll talk about shortly is a voiding diary, and that just helps us figure out, are you having frequency during the day? Is it mostly at night? Do you have the sensation that you're not emptying your bladder completely when you go? How is your stream? Do you have a good stream when you go, or is it just kind of dribbling out? And are you straining to empty your bladder? And then how long has this been happening? Is it something that just came on? Was there any inciting factor? Childbirth is a big cause of incontinence. Was there any falls or trauma that happened before you started experiencing incontinence? I want to look into the medical history a little bit. A lot of medical conditions, common conditions like diabetes and high blood pressure can cause incontinence or lead to incontinence, as well as dementia, or even having radiation for cancer can lead to incontinence, frequency, or urgency. And then we just kind of want to get an idea as to what impact is this having on your life. Is it something where you're limiting your social life, you're not going out because you're worried about how much you're going to leak, or if you're going to be able to find a restroom? We'll also do a physical exam in the office. One thing I like to look at is the lower extremities. A lot of times if you've got a lot of fluid or swelling in your legs, that can cause frequency, urgency, and getting up more at night, because when you're finally laying flat, your body can reabsorb that fluid and it's got to go somewhere, so your kidneys make it into urine, causes you to get up more at night. And then we'll do pelvic exam in women to see if the bladder has fallen, which can often cause incontinence. We'll do urinalysis, which is just a quick urine study in the office, just a urine sample in a cup. That helps us to determine if you're having a urinary tract infection, which can cause frequency, urgency, as well as incontinence. Some people don't know they have an infection if they're just having leakage of urine. You think of the typical symptoms like burning when you urinate, but incontinence can sometimes be the only symptom of a urinary tract infection. A post-void residual, that's this little ultrasound that we get in the office. We put a little microphone over the bladder, and we can see how much urine is left in the bladder after you urinate. Some people, they go to the bathroom and we scan their bladder and they still have 200 or 300 milliliters left in their bladder, and that's their cause of incontinence. They're not emptying completely when they go, so their body's hanging on to urine. And then a voiding diary, I'll show you in the next slide. That's that tool I was talking about that helps us to kind of define your voiding pattern. And if we don't find any obvious answers, we do have ways we can look into things more. Further evaluation, we can take a look at the bladder with a little camera in the office. We can do different imaging studies like x-rays or ultrasounds or CAT scans of the kidneys and the bladder. And then we also have something called urodynamics that we do in our office with our nurses, and that's just a tool that helps us assess how the bladder and the urethra react when we fill the bladder and also when it empties. So here's an example of a voiding diary. Usually it's something that we have you fill out for about 3 or 4 days, and you just kind of mark when you're urinating, how much you urinated, did you have any leakage, if so, how much, did you have the urge to urinate when you went to the bathroom, what were you doing, and then also how much fluid you're drinking throughout the day. That's a really important tool because Sometimes patients are drinking too much water or liquid throughout the day, and they don't know it because it's not anything you think about, and that could be a cause of incontinence as well. All right, so now I'm just going to briefly go over treatment options. There's 3 different lines of treatments. First line treatment options are things that don't involve medications or procedures. So these are behavioral modifications and physical therapy, which Vanessa's going to go over in a little bit. We're really lucky to have these physical therapists. It's a great tool. I send a lot of patients over, and they come back to me 3 months later and say, oh my gosh, it made such a difference, and I'm not taking another medication, which is really nice. Second line treatments, which I'll go over shortly, are medications. There's 2 different classes of medications we'll dive into. And then third line treatments, these are different procedures we can do to help with incontinence. We'll also go into these shortly. All right, so first, behavioral modifications. These are things that you can do, again, that don't involve medication or procedures. The first one is fluid restriction. Again, with that voiding diary, we can see how much you're drinking throughout the day. Over 2 liters of fluid is considered an abnormally high amount of fluid to consume during the day. So that can be a cause of incontinence. And another thing that we typically ask patients to do is about 3 or 4 hours before bedtime, try and limit how much you're drinking, because that will help getting up more frequently at night. Dietary changes. There's a lot of foods and drinks that can irritate the bladder, so we want to kind of limit these things. Caffeine is a big one. You can still have cup of coffee or 2 here or there, but some patients come in and find out they're drinking pots of coffee, which is definitely going to cause frequency, urgency, and incontinence. You want to avoid things like sugar substitutes like aspartame, which are in a lot of sodas, avoiding citrus fruits, highly spiced foods, and tomato products, as these things can irritate the bladder and make you feel like you got to go more often or have incontinence. Weight loss. If you're carrying a little extra weight, we just want to make sure that you're at a healthy weight, because that can cause incontinence as well. Timed voids is a nice little tool you can do on your own. That's just going to the bathroom. We say every 2 hours, if you set a little alarm on your, like on a watch or a phone, and just every 2 hours, go in the bathroom and try to go to the restroom. Even if you're not going a lot, that helps to empty the bladder and gives you less opportunity to have incontinence throughout the day. And then making sure you're having regular bowel movements. Constipation can really irritate the bladder and is a big cause of frequency, urgency, and incontinence. Also, there's temporary or transient causes of incontinence. So these are things that we can fix and that can get better over time. Some of these things are, delirium or infection, atrophic vaginitis or vaginal dryness. Psychological causes like severe depression can cause frequency, urgency, or incontinence. Different medications, diuretics are a big one. The job of those medicines is to get fluid off. That's going to make you go more frequently. Other hypertension medications, high blood pressure meds, certain over-the-counter medications for colds like Afrin, Vicks, Sinex, anything with pseudoephedrine in it, that irritates the bladder. And then also ADHD medications like Ritalin or Vyvanse can cause these symptoms. Restricted mobility obviously can lead to incontinence if you're not able to get up and physically get to the restroom, if that's difficult for you, or stool impaction, again, severe constipation. Okay, so now we're just going to go into some medications. The first class is anticholinergics. These are a medicine that medications that block the action of acetylcholine in the body. So that's just this chemical. Let's say this is acetylcholine, and it binds to these receptors on your bladder, and sometimes it binds too frequently and causes abnormal contractions, frequent contractions of the bladder. So these medications block that overactive binding of acetylcholine with the bladder. Typical side effects that we see, the medications are listed up there: ditropan, Detrol, Toviaz, Vesicare, Enablex, and Trospium. The most common side effect I see if I start a patient on one of these medications is dry eyes, dry mouth, and constipation, which oftentimes patients have these things at baseline. So if you've got those symptoms already, maybe these aren't a great option for you. You can also see urinary tract infections, urinary retention, and sometimes confusion as well. They do fall onto this Beers criteria list, which is a list of medications that are may be inappropriate to use in the elderly or patients over 65, because these side effects can be worse. So I try to avoid these medications, although sometimes people are started on them when they're younger and they work really well, and you can continue them after 65. It also shouldn't be used in patients with glaucoma, as it can make glaucoma worse. And the nice thing about these medicines is if we try one, say we try Ditropan and you've got crazy dry eyes or dry mouth, that doesn't rule out all the other ones. We can try different medicines in this class, so it's not one and done. We have a little wiggle room there. All right, next are beta-3 agonists. There's only one medication in this category, that's Myrbetriq. It's a fairly new medication. It works on the beta-3 pathway on the bladder, so that just helps to relax the smooth muscle of the bladder so that your bladder can store more urine. Biggest side effect with this medication that we see is it can raise the blood pressure slightly. If it does, it's going to raise the blood pressure about 10 points typically or so. So if your blood pressure runs a little high at baseline, this might not be a good option for you. You can also get dry mouth and constipation with this medicine, although it's less than with those anticholinergics, the previous medications. Some people also get nausea and upset stomach. And one nice thing is that it has recently been approved to add Vesicare along with Myrbetriq. That was one of the anticholinergics. So if you're taking the Vesicare, Myrbetriq, and it's been working well, but maybe your incontinence or frequency is getting a little worse, we can add Vesicare along with it to give you a combo therapy. Okay, now third line treatments. The first one we're going to cover, these are different procedures that we can do if medication or behavioral modifications just aren't cutting it. First one is peripheral tibial nerve stimulation, or PTNS, and this is something that we do in the office. You come in and meet with our nurses, and it's almost like a little acupuncture needle, and you put it just right on the outside of the ankle, and then you hook a little electrical current up to that needle, and it stimulates the tibial nerve, and that helps with frequency, urgency, and incontinence. The biggest sort of downfall to this is that it's a little bit time consuming. You come in once a week. It's about a 30-minute procedure with the nurses, and you do this for 12 weeks for the first set. Now, some people notice great benefit with it, and let's say maybe you're doing well, and 3 or 6 months down the line you notice, okay, my incontinence is coming back, things are ramping up a little bit more. Then you can do maintenance treatment where you come in and do maybe 3 or 6 weeks of these 30-minute sessions just to get a booster effect to keep going. All right, next is Botox injection. This is the same medicine that you put in the face to help with wrinkles. We just inject it into the bladder. It's actually an outpatient procedure that we do in the operating room, and that helps frequent contractions of the bladder. The big thing with this, before we do it, you do have to be willing to catheterize yourself, because sometimes this medicine works too well, and then you can't urinate at all after the procedure. It's not a permanent thing. It does wear off. It usually wears off in about 6 to 12 months, but you have to be willing to catheterize yourself in that time if it works too well. And you do need repeated injections, so every 6 or 12 months, if it works for you, then we'll do another injection. And then the last thing I'm just going to cover really quick is Sacral Neuromodulation. This is inner stim. This is where you put these 2 leads into the back that activate a nerve that controls the bladder. There's also a little generator that you put kind of right in the gluteal area, and you have a little handheld device that you program to activate this generator, and that sends impulses down the leads to the bladder to help with overactive contractions of the bladder. Biggest complications with this, pain at the generator site. Those leads can migrate or move, and then there is always opportunity for infection anytime you have foreign body. We do not do this procedure, but if we get to this point, nothing else has worked, we're happy to refer for it. All right, I'm going to hand it off to Cayla. She's going to go over stress incontinence.
Thank you. Make sure my microphone on before I forget.
Hello, everyone. Hello. So I am Cayla. I am a nurse practitioner at the urology group. I work alongside Lyndsey and all of our other doctors we have. And I will be talking to you about stress incontinence. I thank Lyndsey so much because she's already gone over a lot of it. And we will get started. So stress incontinence is kind of the most common form of incontinence, and it's more common in women. It does occur when there is leakage and pressure on the bladder, so things like coughing, Laughing, sneezing, those are the common types we ask about. If you experience those, that is stress incontinence. And the side note to this is you can actually have both types of incontinence. So you can experience urinary incontinence in stress and urge form, and we call that mixed urinary incontinence. Okay? So diagnosis is similar to what Lyndsey had talked about. We do patient history is a big one for us. So even just talking to you, we can kind of determine what symptoms you're having and what type of incontinence you're having. We do like to know about things like childbirth and things like that. And understanding a history from the patient can determine the frequency and severity of the bother of symptoms. If this is very bothersome to you, then we kind of get a feeling of that. If this is minimal at this point, then we can work on things along the way. Okay. There are physical exam things that are different for stress incontinence, slightly. We do things like the post-void residuals, that bladder scan she was talking about, see how much you're emptying, and urine tests are normal for urinary tract infections to see. One of the different things for the pelvic exam with stress incontinence is performing a Valsalva maneuver, or kind of bearing down like you're going to the bathroom during that pelvic exam. That shows us the pressure on the bladder and sees if you leak urine right there in the office with us. It doesn't always happen during that exam, but if it does, it's a pretty common indicator of stress incontinence. Okay. And then considering supplemental evaluation. So understanding that if we cannot figure out what type of incontinence you're having, then we need to delve a little further into things like doing the urodynamics testing with our nurses. That helps us out a lot, and they'll put you through different maneuvers in that test and figure out what type of incontinence you are having. Knowing if the urinalysis, the urine test we do on you is abnormal is helpful, and understanding if you have anything like pelvic prolapse, that dropping of the bladder or uterus, things like that. Okay. One of the things that helps us out a lot in evaluating all this stuff, if you're not able to describe things that well, and we can't get a good story from you, then we do questionnaires. Questionnaires, there are many and multiple of them, and they ask a whole bunch of different questions, stuff like this. Household chores, do you leak during that? Walking, swimming, exercising. Is it affecting your emotional health? Are you feeling frustrated? Things like that. Okay. And all of these tools not only help further describe the symptoms, but can tell us severity, because it can give us actual numbers and say, is your current bother score high enough that we're addressing a whole bunch of things at once? And if we start a treatment and we ask you these questionnaires again, are things getting better? You can do that too. So some of the management options, lifestyle modifications is a big one, which we'll talk about again. Pelvic floor muscle training, which Vanessa and all of her team does. And then pharmacotherapy and surgical options. So lifestyle modifications, bladder training. So we talk about bladder training in the sense of avoiding schedule. So when Lyndsey was talking about doing avoiding diary, doing those types of things can help us determine how often maybe you should time your voids. Maybe you should be going to the bathroom on a 2-hour schedule or 3-hour schedule as needed, and maybe that prevents you from leaking altogether. The other option is seeing that voiding diary, filling out that for a couple days, shows us, is it related to activity or sneezing or excessive fluid intake, all those things. Then fluid management. So when she was talking about how there are bladder irritation dietary changes you can do, the tomato products, sugar, you can also try and cut some of those things out one at a time. So if you cut a tomato product out or spicy foods out, see if that is affecting it. Some of that stuff helps. And then also, constipation is a big one. So using a high fiber diet, having at least 6 to 8 glasses of water a day, and regular exercise, even if it's just 15 or 30 minutes a day, is helpful. And then weight loss, even just losing maybe 10 pounds can help with urinary leakage. The last thing that we talk about too is smoking cessation, especially with stress incontinence. That can cause a lot of coughing. Frequent coughing can lead to frequent leaking. Okay? Pelvic floor muscle training. So I'm going to let Vanessa delve a little bit more into actually these different techniques, but some tips I have for you. So some of the tips are, they're more than just Kegels. That's not the only thing. Okay. Always have your bladder empty before beginning the exercising sessions. I don't think you want to be in a place and leak urine everywhere. It's a key. Counting out loud with long or sustained exercises can help you just walk through those exercises with ease. Keeping your stomach, leg, and muscles relaxed, and deep breathing during those exercises. And then the thing I found, nice little quote that I found that I thought was pretty funny is, squeeze before you sneeze. So, remember that. So, the last devices and surgical options. So there are some non-surgical options that we do in our office. That includes incontinence pessaries. Occlusive devices are non-surgical, but we do not perform those in our office. And like Lyndsey said, we are happy to refer for those. So incontinence pessaries are a device that's fitted to you by our nurses in our office. There's, I think if you look at the box, it's probably this big, and there's like 20 or 30 different options. And you come in for a visit with our nurses, and you go through a few different different devices and see which one fits you best. You kind of walk around with that one in and see if it is comfortable, if it's rubbing the wrong way. You'll try it for maybe about a week or even a couple days and take it home with you and see if it's causing any irritation or anything like that. And you come back and see our nurses, and if that one works for you, we get you one. Okay? And the occlusive devices are basically, in a sense, a plug. Obviously, like I said, we don't offer those, but we do refer for those. And then surgical options include things like injection therapy into the urethra. So that's the tube you pee out of. And injecting that and bulking that area up can help prevent leakage. And then there's other surgeries such as sling surgery. I'm sure you guys have probably heard of those things like meshes and things like that. Like I said, we don't offer those, but we do refer for those, and they do work. So those are kind of our last resort options. And I am going to pass it over to Vanessa now to talk more about physical therapy.
All right, thank you, Kayla.
You're welcome.
So physical therapy, I'm one of the physical therapists in our area that does treatment for urinary incontinence. And we work on the muscles of the body in physical therapy and other areas of the body. So it makes sense that a physical therapist would work on the muscles of the pelvic floor. But what is the pelvic floor? This is kind of a term that sometimes women come into me and they say, you know, I've been supposed to be doing my Kegels, but I'm not quite sure where those muscles are or if I'm doing them correctly. So we really try to go over anatomy and make sure that people know what those muscles are. So the Kegels that you do for these pelvic floor muscles, I don't know that you can see my pointer very easily. The muscles attach to the pubic bone in the front, and I'll pull my little pelvis here too. but this is a cross view of the anatomy. And this would be the pubic bone in the front, the tailbone, and called the coccyx in the back. In between there are the muscles of the pelvic floor. Those are what we're talking about when you do the Kegel. And I like to refer to those muscles as a hammock. And I don't know if you've seen people hammock before, or if you've tried yourself. When you hammock, you need to tie that hammock between two trees pretty taut. If you don't tie it tight enough, then you might fall down and not have support in your hammock. You might even hit the ground. Similar to those muscles of the pelvic floor, we need them to have good strength in muscles and ligaments to do their job. So what does the pelvic floor do? Those muscles are to support our pelvic and abdominal organs. They also provide stabilization through the pelvis. They assist in both bladder and bowel continence, and they enhance sexual function. So this is a picture of muscles that we work on. And again, this would be the core muscles. And what is the core? That's another term that we hear, and it's a little unclear of what the core is. So the top of our core is the diaphragm. That's the roof of the core. One more time, I'm going to try to use but I think I lose it a little bit. But that diaphragm is our breathing muscle right under our ribs. That's the roof of the core. The floor of the core, the bottom of our canister and core, are those pelvic floor muscles that we talked about, and the pelvis. The front of our core are transverse abdominal muscles. And those transverse abdominis muscles, I like to use the term that they're an internal girdle. They're underneath our typical outside rectus abdominis, our muscles that we work when we do sit-ups. But underneath those are the transverse abdominis. They also attach down into those pelvic floor muscles, so very important for incontinence. We also have the muscles along the back of our spine. On either side of our spine are the multifidus muscles, also important for urinary incontinence. It's important that we look at that whole core of muscles, not just the pelvic floor. And so many times I and my colleagues are amazed that women have suffered in silence with incontinence for 8 to 10 years before they seek medical attention or really think to talk about it with their friends or family. It's almost like it's a taboo topic. I don't know if you can read my comic, but it says, whenever someone tells me, "You go, girl," I generally have to. And I like that. It's a woman talking probably to her sister or a good friend. I always tell people after they've gone through therapy, spread the word to your friends and family because we can help. So we think of 5 Ds of urinary incontinence. Debt. Incontinence is expensive. The special products that are sold for incontinence work well, but they're not cheap. And as time goes on, you're needed to use more and more of the pads, and that's expensive. Medication is expensive. Delayed response is our second D. Incontinence is secret. Again, women don't like to talk to family members or friends or medical providers even about incontinence. It's dehumanizing, our third D. Incontinence causes insecurity. When we talk to you about how it's affecting your life, we hear that, I'm not going to the movies because I don't want to get up repeatedly to use the restroom. I'm not going to dinner with friends or to church or to bingo, to things that I enjoy because I feel like I'm leaking and I don't want people to know. And then it's debilitating. Over time, incontinence gets worse if it's not treated. But with determination, good news, incontinence is not inevitable. And so what do we do in physical therapy? So we'll have you come in and we'll talk through your symptoms. We'll talk about what things are you having trouble doing because of incontinence. What's your functional loss? How is your bladder and bowel functioning? And we'll get some of that information too from the doctor's office. What are your goals? Everyone's goals are a little bit different. Some moms might want to be able to go and jump on a trampoline with their kids. Other women might want to go out to dinner with their friends. What are your goals? And then objective measures. We'll look at strength of pelvic floor. We'll talk a little bit more about the EMG, a surface EMG that gives us biofeedback. It lets us know how your muscles in your pelvic floor are contracting and relaxing. We'll look at that core that we talked about and do a breathing assessment. Again, looking at movement of that transverse abdominis. And we'll look at your hips and your back as well as your pelvic floor, all of the muscles, and special tests as we see appropriate. So this is an example of our surface EMG. We don't put everyone up on a wedge with a ball. We could progress to that, but what's nice about it is it gives the patient good visual feedback of, okay, this time my muscle is contracting, I'm getting the pelvic floor contraction, now I'm relaxing. And we therapists talk you through contracting and relaxing those muscles of the pelvic floor. And this is an example of one of my patients that had good contraction. So these upper graph points here are the contractions of the pelvic floor. Then inversely, she had good relaxation of each contraction. And that is a good pelvic floor. It's giving good contraction followed by good relaxation. Just like if I were to have a tight biceps muscle, I can only get so much more contraction out of that muscle. I want my biceps muscle to fully relax and then fully contract. That would give me optimal contraction. Same thing in the pelvic floor. We like to look and get complete contraction and complete relaxation. This is a different example of a patient that was just starting out with me. And as you can tell, her peaks are pretty much all towards the top. She's not getting that good relaxation that I'd like to see in between each. She had a lot of tone and her pelvic floor was really guarded. And so wasn't able to get good contraction then in the pelvic floor. So we worked on retraining. So what do we do for treatment? We love to educate. We give you a folder when you come in your first day, and each time you come, we add education into that folder. We love to just give you as much of our knowledge as we can and talk about different aspects of incontinence. The muscles that we identified that were weak, we strengthen, not only in the pelvic floor, but in your core, in your hips, in your back. Relaxation, those muscles that are tight or guarded, we relax those muscles. And we work on breathing exercises, diaphragmatic breathing, that movement of the abdomen, so important to work on the core contraction, but also relaxation, all play into urinary incontinence. We do things called urge suppression and knack techniques, similar to what Cayla had mentioned, that we have you squeeze the pelvic floor before you cough or sneeze or lift or do different things. Lots of training of techniques. And then we talked about the EMG, that surface Electro Myography biofeedback. It does retraining from the brain to the bladder and the brain to the pelvic floor, all trying to coordinate those things to help incontinence. Treatment tools. So we have a variety of things that we can use with different patients. Every patient's a little bit different. So some patients might not be able to contract the muscle at all in their pelvic floor, or it's so weak. And for those patients, we might use some electrical stimulation to try to help that muscle to contract. It would be a little tingling sensation that you would feel that would help the muscle to contract. We also have tools to stretch or work on tight muscles. We even have weights, believe it or not. And then we have an extensive lending library. Myself and the therapists that I work with, we just have a quest for knowledge in this area, and we're always adding resources into our library, and love when patients want to learn more about incontinence or different painful pain in the pelvis. And so these resources are available for us to check out to you as a lending library. Our pelvic health suites. I wanted to include a picture because people think, oh gosh, first, I didn't know physical therapy did this. And then, am I going to be out in a gym in the middle of everybody? And oh my goodness, that's awful. So we have private rooms and private bathroom connected to our room, because chances are when you come for treatment with us, you'll probably need to use the restroom. And so it's nice and close and private for you to do so. So our training, I'm one of 5 physical therapists within the local Lakeland, Spectrum Lakeland system that have been trained and are certified in pelvic health from the American Physical Therapy Association. We also just have a quest for knowledge in our field and are continuing to do continuing education to try to keep current on the latest in treatments. So what should you expect during your first visit? We're going to talk through your symptoms so we can best understand what's of biggest concern to you. And we want you to know that therapy is a safe place without judgment. So often people come into me and they say, what if I leak during exercise? Or, you know, I just don't know if I should be here. You definitely should be here with us. And it's okay if you leak, because we have seen it all before. And this is what we do. So absolutely a safe place. And again, we love to educate. We go over anatomy and physiology of the bladder and the pelvic floor. We like to really work on the muscles of the pelvis, but also the lumbar spine and the hips. We work with bladder function and give you some tips. Lifestyle modification, like Cayla talked about, bladder irritants. We review those with you. The importance of sleeping and maybe not getting up so many times during the night, and how can we help with that? Physical fitness really is important to get that muscle control back. So getting active, we work on as well. So we might have you do some exercises out in our gym as well. Posture, we look at your posture and how can we correct abnormal posture. Home exercises. We go through breathing exercises. We make sure you know how to do those Kegels, the contraction and relaxation of the pelvic floor. We discuss your goals, and then we come up with what's our plan? What are we going to go, how are we going to proceed? Everyone, like I said, is a little bit different. And so we just like to make sure that we're individualizing your plan of care. And then we go over expectations for your next visit. Each time you know, okay, when I come in next time, what are we going to be doing? And you have that, that ahead of time. So the good news is that between 69 to 85% of women can be helped with conservative measures. And we see a significant improvement in urinary incontinence with physical therapy and conservative measures.